Hi, my name is Delilah Masick. I'm currently a PGY2 critical care resident at Loyola University Medical Center, and today my presentation is titled Getting Out of the Red, focusing on anticoagulation reversal. So really, by the end of this presentation, you should be able to describe the pathophysiology of the coagulation cascade and summarize the role of anticoagulant reversal agents and recognize the situations in which their use is appropriate. So to start it off, I'd like to relate it to a patient case. So we have CC, who's a 54-year-old male on rivaroxaban for the treatment of a deep vein thrombosis. So he presents to the ED with the chief complaint of fatigue and bright red blood per rectum. While in the ED, he uses the restroom and he reports bloody stool to the nurse. His vitals are measured. His blood pressure dropped from 140/80 on admission to 93/52. So real life scenario that happens in most emergency departments. So the ED physician asks you for your recommendation on the best agent or agents to reverse patient CC's bleeding. So to start off, the coagulation cascade is made of the intrinsic system and the extrinsic system. And we have many, many factors that all lead down to fibrinogen converting into fibrin and ultimately forming a clot. I'd like to pay attention to this picture since most of the mechanism of action of our anticoagulants or anticoagulation reversal agents relate back to this pathophysiology. So the first one I'd like to start off with is heparin and low molecular weight heparin. So heparin, as you can see, it's a really long side chain. So it binds and activates to antithrombin, and it really inhibits factor 10A and 2A in a 1-to-1 ratio. Please note the short half-life of 60 to 90 minutes. Whereas low molecular weight heparin, such as enoxaparin, binds and activates also antithrombin. However, it's much shorter side chain, inhibits factor 10A more than 2A, and please note the longer half-life. So if patients do bleed on heparin or low molecular weight heparin, the reversal agent of choice is protamine. So this actually binds to either agent and forms a stable salt to really neutralize those anticoagulant effects. Adverse reactions are noted, so we have to push the medication slowly, and the dosing is noted as well. So really important from a pharmacist perspective, a pearl is to know how much heparin or low molecular weight heparin the patient got and how long ago, because their dosing for protamine really depends on the heparin or low molecular weight heparin dosing and timing. And of note, the maximum dose of protamine is 50 milligrams. If we have to exceed 50 milligrams, then we must wait a time period. Furthermore, I'd like to talk about warfarin. Warfarin is one of the most commonly used anticoagulants. It inhibits clotting factors 7, 9, 10, and 2. So SNOT is an easy acronym that you can remember that. It goes from shortest half-life to longest half-life. That's why the range varies from 20 to 60 hours. 4-factor prothrombin complex concentrates, as well as vitamin K, both reverse warfarin. So 4-factor prothrombin complex, as you can tell, increases the levels of those cofactors, so 7, 9, 10, and 2, as well as protein C and S. As you can see, the dosing really depends on the INR. So as the pharmacist in the ED, the first thing you want to do when the patient arrives with a bleed on warfarin is make sure that we get that INR. Don't forget, we really need to co-administer vitamin K just because K-Central or 4-factor PCC lasts about 10 minutes, or I'm sorry, the onset's about 10 minutes, lasts about 6 to 8 hours. But we need that vitamin K to really make those clotting factors from the liver past those 6 to 8 hours. There's different PCC formulations depending on which institution you are training at. And please note the differences. Some contain heparin, whereas some don't. So that's important if patients do have hypersensitivities to heparin, like heparin-induced thrombocytopenia. Next agent I'd like to talk about is dabigatran or Pradaxa. So this agent inhibits thrombin, so factor 2A, and excretion, it's important to note that it's renal. So if we inhibit 2A, we stop fibrinogen converting to fibrin, and therefore we get our anticoagulant effect. However, when a patient bleeds on dabigatran, we actually have a reversal agent called idarucizumab. So this is a monoclonal antibody that binds to dabigatran, and then both the antibody and dabigatran get excreted out through the kidneys. The dose is 5 grams IV times 1, and it comes in 2 different boxes, so 2.5 grams, 15 minutes apart. Next, I'd like to talk about our factor 10A inhibitors. So these agents have gotten more and more attention. So rivaroxaban and apixaban, So they inhibit factor Xa and prevent the forming of fibrinogen to fibrin. There are differences in excretion as well as half-life. So what we can use currently is 4-factor PCC. We can use this off-label for patients who bleed on factor Xa inhibitors, and there's real controversy in terms of dosing. Some institutions use the weight-based dosing, which is 50 units per kilo with a max of 5,000 units, whereas other institutions have switched over to more fixed dosing so that everyone gets 1,000 to 1,500 units. Some pros of fixed dosing include cost savings, because we're giving much less drug, but cons, we really don't know if this fixed dose is insufficient in our patients who are heavier or more obese. Fresh off the market, so we have a new agent called Indexin Alpha, and this is a little bit different than idarucizumab, in which this is a decoy protein. So it kind of looks like factor Xa, so the factor Xa inhibitors bind to this decoy protein instead of actual factor Xa. The dosing strategy is listed below, so there's a low dose and a high dose, and it really depends on what the last dose of apixaban or rivaroxaban is and how long ago the patient presented from the last dose. And this table shows our dosing scheme. However, keep in mind that Indexin Alpha is currently not readily available, but it may be more readily available within the next few months. So as a summary, we use Protamine for heparin, enoxaparin, or dalteparin. For warfarin, don't forget, we need vitamin K with our 4-factor prothrombin complex concentrate. For dabigatran, we can use idarucizumab. If institutions don't have idarucizumab, we can use 4-factor PCC or even hemodialysis since it's renally cleared. And finally, for apixaban and rivaroxaban, we can use 4-factor PCC off-label if we don't have Indexin Alpha, or since Indexin Alpha is becoming more readily available, that would be the treatment of choice. So bring it back to our patient case. So our patient presents with a lower GI bleed, and he's becoming hemodynamically unstable. So because he was on rivaroxaban, we recommend 4-factor PCC, 50 units per kilo with a max of 5,000 units, since this institution per se did not have Indexin at all.